In my experience of working with youth and families, when I started this work more than a decade ago, it was my kid has depression or they have anxiety or they're self-harming. And today, especially post-pandemic, the level of acuity is so much greater than it's ever been. Now my kid has depression, anxiety, they're skipping school, they're self-harming, or they're using substances to cope. It feels like we're collectively a pot that's about to boil over.
When we see issues with kids, when we have a diagnosis, or even if we don't have a diagnosis, but we know they've got a challenge and we might be able to stave it off from becoming a diagnosis, EPSDT calls for Medicaid to cover the treatment that is needed to address or even just ameliorate or help reduce any of those health problems or issues that are found. It's a pretty obscure acronym. It's pretty technical sounding.
And it's hard to say.
And hard to say and explain, and you're like, oh.
So the place that we really want to start with you and use your expertise is to really understand much more specifically what each part of this fun acronym means by way of what does it actually require in practice. Hi, I'm Heidi Baskfield, Executive Director of Speak Our Minds.
And I'm Jason Hopcus, the President and CEO of the National Alliance on Mental Illness for Arapahoe-Douglas Counties in Colorado, and the founder and president of Connection Project, and the host of Nobody's Perfect podcast.
And today we are so excited to have Senior Managing Director with Manat Health Strategies, Jocelyn Guyer, who is known throughout the country as being one of the foremost experts in Medicaid and specifically EPSDT. So we're so excited to have you with us today, Jocelyn. Thanks for joining us.
Yeah, I'm happy to be here. Thanks for having me.
We're going to dive right in because we've been spending a little time leading up to this, really giving a sense of the way that Medicaid is unique in its comprehensive extension of access to care and what it covers, and that is really this signature component of all that allows it to stand alone and differently from other programs and insurance and things like that. And so the place that we really want to start with you and use your expertise is to really understand much more specifically what each part of this fun acronym means by way of what does it actually require in practice. So if you could take us through early, periodic, screening, diagnostic, and treatment, and help everyone who's listening know what is this thing and how am I supposed to relate to this?
Yeah. Okay, let's do it. So just to say, first at a high level, all of those letters come together into the acronym EAT, which I think of at its heart is a way of describing the medical care that we're going to make sure that children enrolled in Medicaid in this country have, and make sure that it's individualized and tailored to what they need and based on clinical and medical necessity, not what your insurance company thinks might be a good idea, what the federal government thinks might be a good idea, but really what is it that kids need to grow and thrive. So that's the big picture, but let's do kind of each of these letters one by one. So early is alluding to, we want to catch kids and the challenges they face early before they develop into more complex problems that are harder to treat. So right from the very beginning of your life on this earth, making sure that you have access to the chance to be assessed and figure out how things are going and find those challenges and problems early so we can treat them. Periodic stands for, we're going to touch base periodically, literally every now and then at age appropriate intervals, and check in on that young person's health. So there's a lot we can talk about down the line in terms of how states define and think about how to set that schedule of periodic, but the concept is this isn't a one-off thing. We really need to help kids grow and thrive, be checking in with them regularly on how their health and what's going on. Screening is that high level, let's see and so ask everybody and catch and figure out if there's challenges or issues or emerging problems in a whole range of spaces. So the screening covers everything from your physical health to your mental health, to your developmental health, to your dental health, to hearing, vision, and really any other screening test that might be used to protect potential problems. Diagnostic is when you sort of start to get into the kind of more traditional medical care where it's like, I've got something that's come up on a screen. Let's figure out what's going on. And so it also encompasses performing those diagnostic tests that you need to follow up when a risk is identified. And any of us who have lived it know those can be actually pretty intensive and expensive. And that is a core part of what's covered. And then the last letter is T for treatment. It's my favorite letter because it's the part to me as a mom and as a policy analyst that really matters, which is when we see issues with kids, when we have a diagnosis, or even if we don't have a diagnosis, but we know they've got a challenge and we might be able to stave it off from becoming a diagnosis. EPSDT calls for Medicaid to cover the treatment that is needed to address or even just ameliorate or help reduce any of those health problems or issues that are found. I don't know if that helps, but that's how I think about it.
Yeah, and that it does help. And when I think about EP in terms of the experience on the physical health side, like people get that, like they know that experience really well. They can sort of go, oh yeah, that's how that applies. But I think what we're really trying to have people understand is that that same expectation can and should be in place on their mental health. So can you talk more about sort of in a mental health context, how you feel like EPSDT is best being applied? I mean, you can even give an example of a kiddo in a condition or however you want to paint that picture.
Yeah, absolutely. And just to kind of pick up on where you are, like we can all remember and imagine, like you get checked regularly. Are your eyes working? Do you need glasses for school? So EPSDT provides for and allows that analogy with respect to mental health. So and it depends a little bit on the age of the kid as to the example that's going to resonate. I remember that E for early. So from the very beginning, even the youngest of infants, what a pediatrician or someone may be looking for is how's that family relationship going? Is there anything that we're seeing that we should be screening for where maybe it's a parent who might need some extra support, figuring out how to develop that strong attachment, figuring out how to respond. So that is part of the screening that we can be doing. As kids get a little older, we might be screening for social and emotional challenges and issues, and there's tools to do that. So how is the little one doing in terms of interacting with others, managing their emotions? And then obviously, as you get into the teenage years, you hear more traditional screenings like depression and anxiety screening can be a part of ET as well. And substance use, because I don't want to forget substance use, which is a big part of, I think, for many of us, what we need to be supporting our young people with.
I love how beautifully and simply you have made this complicated to say acronym for us. Thank you for giving us some more insight into exactly what's entailed with that. So when you talk about this, I hear, this really robust program that kind of meets people where they are and then follows them along the continuum, which I think is amazing. How individualized is this system, first of all? And then, what does medical necessity, what role does it play in kind of shaping some of this as people move through the process?
Yeah, I think we might want to talk about kind of on two levels. We'll do the theory and what's in the statute and the regulation. And then I just want to acknowledge this is not the reality on the ground for all of us as we go through life. And part of what we may be talking about is like, how do we make the theory become the reality for all the kids across the country? So, I mean, the theory with respect to individualized services and medical necessity is that it's highly individualized. Unlike, again, you can sort of think about some of what we do to adults, which is you get 12 physical therapy visits a year and that's it, right? We don't care if you broke your leg or if you sprained your finger. It's 12. EPSDT requires that Medicaid as a health insurance program pay for whatever a clinician and a family and a young person together that decide is needed and medically necessary. So if you need to, let's just take a mental health example. Maybe you're really struggling in adolescence and one therapy visit a week isn't enough. You really need to be touching base more frequently. So it requires that kind of individualized assessment. And if that is what is medically necessary, then it needs to be provided. To me, I think the key feature is it really tries to empower and make the decision making based on what the provider and the family together think is needed, as opposed to our more traditional, this is what our insurance company is willing to cover and what they're not.
And that's why I love this so much. And that's why I just want to talk about it all the time, because it's like, this is what healthcare looks like when it works well. It identifies your specific needs and makes sure that the services are there then to address those. And then we keep asking, is it working? Is it working?
Right.
And yeah, it's amazing. And when I think about that's big, that can be broad at times and maybe expensive. I mean, EPSDT was designed to be a cost savings measure in some ways, right? So Jocelyn, can you talk about how that theory sort of applies in this space? Like, how is something that's supposed to be so tailored to the individual also meant to achieve cost saving?
Yeah, and I think it goes back to that foundational, we're checking in early, we're checking in periodically. So if we can catch things before they develop into much more serious conditions, it can be cost effective. And so just to do a behavioral health example, if we've got a 9, a 10, 11-year-old who's really starting to show some anxiety and school avoidance, there's a couple different paths that could take. I mean, one is if we catch it early and get some intensive support, cognitive behavioral therapy to cope with the anxiety, maybe some school-based support so that it's not just a traditional outpatient clinical visit, but also some support in the schools. Maybe they figure out how to get through middle school and to high school. If we don't catch it and they start using substances to cope with the anxiety, then we get into much higher risk territory. And some subset of those young people are going to land in psychiatric hospitalizations, intensive residential treatment, intensive in-home. And so I think that's the foundational logic, is if we can catch things early and provide that support, we can create a different trajectory for our young people.
And what I love about what you're saying is it really feels like a system that is rooted in meeting people where they are, seeing them, understanding their unique challenges and circumstances, and really starting from there. And again, hopefully starting early and then periodically as they move through.
Exactly. Yeah.
From your vantage point, how do you think children's hospitals, providers, or school-based programs can better align their care models to take full advantage of the protections provided with EPSDT?
Yeah, well, I think some of it, and it's what I see Heidi doing and what I see you both doing with this podcast, is we have to get the word out, right? Because it's a pretty obscure acronym. It's pretty technical sounding.
And it's hard to say.
And hard to say and explain. And you're like, oh. So I do think some basic education on what's required to support our providers in understanding it, because as the individuals who are on the front lines in working with our kids, if they are empowered to know that the young people they're working with have a right, and it is an entitlement, they have a right to the services that they need, that will make it much easier for them to go ahead and ensure that that happens. So I do think the basic education is critical. I would say the other piece I would lift up, and that is actually manifest in some guidance that came out a couple of months ago on EPSDT that came out of the federal government, is it's not enough just to kind of wait until a kid has an issue and you're like, oh gosh, this is tough. We should probably have a mobile crisis intervention tailored to kids. The EPSDT structure and regulatory requirement is that there be affirmative thinking in advance. Like, we know a certain number of kids are going to need this. How are we setting up our systems to make sure it's there? And I think that's a place where children's hospitals, providers, and school-based programs can be part of that creative thinking with states on what is the system that we need to have ready so that we're ready when a kid comes in and needs more intensive or a different venue for the therapeutic support that they're receiving.
When you talk about that, Jocelyn, my mind immediately goes into thinking about that Medicaid is a state-based program, and it has so much variation in how it's working in all 50 states. And so as you think about the implementation and youth mental health, and you're in all the places and spaces, do you point to any particular state and say, they're doing this really well? And if not, because maybe there isn't one, who or what models are you pointing to say, okay, no one state is sort of the beacon of hope yet. There are many that are working on it, but here are some things that I would say in this state that is working well, or in this state that I think should be replicated.
Yeah. And I might go down your later path. think of it as like the smorgasbord path. Like we've got some really strong elements in different states. I don't think any state has fully cracked this nut. And I'm sure if you talk to families in any state, there's going to still be just barriers they're hitting. So, but I think there's a couple key elements, and then let's talk through some of the states where it's happening. So the first is to do that basic outreach. We talked about outreach to providers, but also outreach to families so they know what they should be able to expect and look for. And there are states like California that have put together very strong consumer-facing educational materials, short pamphlets, things that you could potentially read while you're bringing your kid in for a well-child visit. And so I think one foundational piece is that consumer-facing education and work, just to get that out there. And they're good places to look for that. To me, I would say that the second thing that I'd be looking for is there staff and support within the state Medicaid agency to do that affirmative work to make sure that EPSDT is happening, that providers know about it, that they've done a review and made sure that the services are there. And there are places, DC is one, where for many years they have dedicated staff that are thinking about EPSDT and how to make sure it's getting taken advantage of. The other thing I'm looking for when I think about states that are doing well is which states have really, from a behavioral health perspective, is which states have really thought about the treatment piece of this and have started to put in place the services. And I all kids and all the full array of needs are really important. I tend to sometimes really worry about the kids that are in the deep end of the mental health and substance use system. And so there are states there that have really reached to try to figure out what are the services those kids need. Some of them have done it in response to being sued. So I'll just be honest about that. So it was sort of from a happy meeting of people who probably wanted to do it, and then a little litigation saying like, you really got to get your act together on this. Yeah. And so a couple places that have the lawsuits under their belt and have embraced it include places like Massachusetts and New Jersey, where they have set up comprehensive continuums of care. They're always got to go back and work on them. You know, they're always working on them, but they have those intensive in-home supports. They have mobile crisis teams that are trained to work with kids and families, because it's not the same thing to walk in to help a family that's got a 13-year-old as it is to walk into someone who's a 42-year-old who's been living with significant mental illness for a while. So those are some of the ones that I would look at and think about. But no single state has all of the elements that I think we'd want to see.
You know, I love, again, how you've laid this out for us, and recognizing that, you know, that there is a path that has been designed and aligned to support people and kind of meet them where they are, I think is so incredible. And just the awareness of nobody's doing it perfectly yet leaves a lot of room for opportunity and hope. I guess aside from having opportunity and hope, like looking ahead, what policy or system changes do you think need to happen to really unlock the full potential of EPSDT to improve youth mental health?
Yeah. What I would be looking for is in each and every state, an affirmative effort to review where they are on it and to put in place and to like a data-driven effort to assess what's happening now? How well are we doing in terms of our screenings and reaching kids, but really based in the data? A clear assessment of what's the range of services that we've affirmatively set up? What's the provider support we're offering for those services? And then I would say so my sort of single ask is an affirmative review and data-driven assessment of how to improve it. As part of that, I would want families front and center. So as part of that review, pull the claims data for sure, understand who's getting what, but then also talk to families and young people directly. What's your experience been? Have you been able to get the services you need? What are the biggest gaps? So I would like to see that comprehensive review with both data and family and young people participating actively in it.
And what do you think is the obstacle from that currently happening? Is it underfunding, understaffed, all of the above?
Yeah. Okay. Let's think about that. There are a couple different obstacles. So I do think funding is an issue, and we're now entering obviously an era where there's a fair number of pressures coming to Medicaid programs. So we are going to have to continue to keep the focus sharply on what our young people need. So just to say, absolutely funding. I would say though, more than that, it takes a reorientation of state leaders from what is often a well-earned, somewhat defensive position of we're trying, we're doing the best we can. We might get sued. We don't want to admit and acknowledge there's challenges and issues, to really turning it to say, let's go out and figure out what is happening by looking at our data and talking to families. And that can be a scary thing to do. It is why I think sometimes we see these types of initiatives actually in the aftermath of lawsuits rather than in front of them. But I say, let's get out there and do it before there has to be litigation over it from the states.
Well, it's certainly a proactive approach,
Proactive approach, yeah.
And the good and the bad of that is you get the information, but then you also have to do something once you have
to do something. And it's honestly, it's excruciating. We've helped a couple of states do this, and it's excruciating because when you talk to families and you hear what they are going through, it can be just incredibly emotional to hear how much they are wrestling with and how much the system isn't meeting the spirit of EPSDT and how much more we need to do. But I kind of think we got to go through it. I mean, we just got to look at it and figure out our path forward.
And I just think if I'm a parent that's listening today, and that's the broad part of our audience that we serve here at Nobody's Perfect specifically, and this is all new information to me. Like, what do I do aside from listening to the series? What do I do to get better rooted in these are my rights? I'm entitled to this for my child. How do I get on the path, so to speak, to really advocate for the experiences that I'm having at home?
Yeah. This is a place where I'm a big advocate for families connecting with each other, because I think it's really hard to do on your own. Yes, you should have the information. So when you talk to your young child's provider, you can share with them and maybe nudge them. But I feel like this is a place where we want families coming together, because together they can see the system's issues. And then it's a little easier to organize a conversation with states or children's hospitals or others to say, here's where the gaps are. So I would be really encouraging folks to connect with other families, use the resources that are out there, whether it's NAMI or family-led groups or others, and become part of that advocacy effort.
I also wonder too, Jocelyn, like when you talk about the fact that there isn't a single state, and I agree that we point to and go, they've got it. Like they are doing this well. When we think of how big of an effort has to continue to be made across this country to get a benefit package that, has been around since the 60s fully implemented, it makes me wonder, like, are you hopeful? Are we going to be able to do this? Like, what's it going to be? What's it going to take from all of us to really move from sort of being a secret to having it be like out there, known, advocated for, sort of in the zeitgeist, if you will, of Medicaid discussion?
Yeah. So I feel like it's almost like a personality test. I am hopeful, Heidi, in part because that's how I go through the universe and cope with just the challenges that arise in life. Is like, I feel like we have got to make the progress, and we will. And there's so many people who are passionate about these issues because they have their own lived experience, or they see loved ones in their family or friends coping with it, that I do think there's a strong, and it's nonpartisan, and it's across the entire United States, and it's geographically diverse, it's rural, it's urban. I think there's a strong commitment and passion about making things easier for our kids and helping them. And so I don't think it's going to naturally happen, but especially if families can come together, I think there's a well of interest and support there that leaves me optimistic that with lots of work, we can get there.
Well, and I also, what I'm hearing from you, and I don't want to put words in your mouth, like, this isn't just a problem that people aren't aware about because of money. Like there are other factors that fit into this, which again, I think adds to the hopefulness of this. I'm wondering, for your perspective, in having done this, in such a deeply rooted way, in my experience of working with youth and families, when I started this work more than a decade ago, it was my kid has depression, or they have anxiety, or they're self-harming. And today, especially post-pandemic, the level of acuity is so much greater than it's ever been. Now my kid has depression, anxiety, they're skipping school, they're self-harming, or they're using substances to cope. Like, it feels like we're collectively a pot that's about to boil over. And I wonder if that increase in acuity and that demand on the system that has been placed on it, do you think that that's a step forward in driving these conversations forward, and the necessity behind why we've got to make this easier?
I do, Jason. I feel like people's lived experience is such that there's greater urgency on it. It's both more people affected. I think we've always had young people who've struggled, but I feel like it's more now. And then on your point, it's the intensity and just sense that young people's lives are at stake, right? Whether it's we might lose them to suicide, or the drug supply right now is a nightmare and Russian roulette every 9 minutes. So it's higher stakes than it has ever been to get this right and to figure out how to help our kids and get them the tools and support they need to grow and thrive and get through what they need to get through.
Well, and just to really reiterate that if you're a parent that's listening, like EP really has the potential to be a release valve to help make the path clearer. Because what I have found is people don't learn about mental health until it hits their home typically. And, we have a system that has not seen mental health as health. And we're navigating all of these complex things that have been put upon us as a society and individually within our home systems. Like, it's a lot. So like normalizing the fact that everyone struggles, we are all going through something in our own way. And like, this really is a path to make things far clearer around next thing next.
Yep. And I'm glad you said that, because I actually wanted to go back. You had asked about barriers to moving forward. I did want to talk about stigma too, which I do think is still there. And there's such a risk even now of when families step forward and assert what they need, of like just that little, well, that wouldn't happen to me. That wouldn't happen to my kid. That I think it's almost a protective factor. Like, I don't have to worry about that because that wouldn't happen to me, but it does happen to everybody. And that's why I think we're making progress on stigma, but I feel like we still need to keep our eye on it and just make sure that that's part of why I like families coming together, because that's one of the powerful tools against stigma, but making sure that it's not infiltrating and continuing to adversely affect sort of the willingness to step forward and come up with affirmative solutions.
Well, and it also evolves the us versus them conversation, to your point. Like, that could never happen to me. And, again, I didn't think that having a breakdown at 37 was going to happen to me either. And it did in an extraordinary fashion. And it literally shaped everything that came after that. But, I think there is an awareness and a reality of, while these tools are incredibly powerful to support kids, like even as parents listening, I mean, we all have a lot on our plate, and the roadmap to navigate it is filled with landmines at best. And I love your part about community, because I feel like bringing us together in community is really the foundation of connection and how we heal together.
Yeah, I think it helps both on the issues we're really focused on, which is how do we make it a reality? Like, it's easier to do advocacy together. And then, of course, I do think it helps with the potential isolation that comes if your kid is really struggling, and it helps with stigma if we band together. So kind of win-win-win-win from my perspective in terms of families supporting each other and working together on these issues.
What do you think it's going to take state leaders, state Medicaid leadership, to embrace this ground up approach to system design? Because what it feels like more often is still, even with best intentions, top down, state driven, like, we have to own this because of, our legal obligations, which in the end, like, cuts off critical engagement from the very people who need the system. So as you're in these places with these leaders, like, how can we help them feel that ground up is going to get you further faster in complying with those legal obligations, as opposed to like the other way around?
Yeah. So agree with the description of the dilemma. And part of what I've seen that gives me some hope on that is we have seen states that have, and I'll give you the example of the state of Maryland. We were actually just in the final stages of this, but they decided, I think probably because a lot of times what happens is one of the state leaders has their own challenges and issues, right? It's very motivating. So I'm not sure who or why, but Governor Moore in Maryland has been very committed to this and had his state behavioral health agency do that kind of affirmative review on what young people need and set it up so that it was driven by a family-led organization. And then we happened to get to help. We did the policy piece of it, but they set it up from the beginning with families, and it was based in part on data, but also on family focus groups from around the state. And so I think if we can get those examples out there more of how engaging families from the beginning both makes it a much more powerful effort, but also when people are involved, they're more willing to help you solve problems instead of just standing outside and kind of lobbying critiques and complaints, well-founded critiques and complaints, but they're much more willing to try to help you figure out how to problem solve if they're part of the process. So I think we lift up those examples and we keep spreading them, try to reorient mindset.
I love how beautifully you've laid this out for us. And I think the word that has come up a lot in this episode is hopeful. And really being able to end this episode on that hopeful note and recognizing that, nobody's doing it perfectly. I don't think there's an expectation that they should or they will, but really being rooted in the reality of it's going to take all of us to get on a page and go down this path. Like that's essential.
Yeah, absolutely. Absolutely.
Well, Jocelyn, we can't thank you enough for being part of the conversation today. There's a lot, as we've talked about, and we'll continue to talk about, a lot evolving at the federal level and at the different states. And we'd love to keep talking about this with you going forward. So we hope you'll come back and help us give progress reports on what we're seeing and how we continue to equip our listeners with the tools they need to be engaged and get what they need. But thank you so much for joining us today.
Oh, well, thank you for having me. And thank you for all the work you're doing. I would love to have this be an ongoing conversation.
It was such a pleasure. Thank you, Jocelyn.
Thanks, you all.